maternal fetal medicine. This is on postpartum hemorrhage, and we're going to discuss in detail identifying risk factors as well as management. And I know we'll be speaking to areas with different levels of access, so we'll try to cover it in detail regarding what you may or may not have available and what may need to be referred to a tertiary care center. The outline, we have some learning objectives, the overview of reasons for hemorrhage and postpartum classifications, the treatment options, and approach to massive transfusion. The learning objectives to understand the etiologies of hemorrhage in our obstetrical patients, a list of maternal fetal conditions that can precipitate hemorrhage, outline hemorrhage care and hemorrhage staging. Before bleeding ever occurs, we need to know basically some areas of recognition, readiness, response, and reporting. Recognition and prevention sometimes is identifying the risk assessment as well as universal active management of a third stage of labor. And just a reminder, the third stage is after delivery and dealing with the delivery of the placenta and immediately afterwards. Readiness should be for every unit. I know we have some limitations on blood bank accessibility, and we'll talk a little bit about massive transfusion protocols, though I know, again, some hospitals will not have enough blood products to be able to truly have a protocol. Hemorrhage cart and medication kits are very important. Hemorrhagic team with drills for all the stakeholders, including nursing and physicians, as well as lab people, blood bank, and other ancillary individuals. The response, a checklist is always helpful. In these situations, they can be rather chaotic, so we have to remember regarding all the other family members and other staff that are present. Reporting a culture of huddles and debrief. The point of the debrief is again to hopefully review our successes, but also identify areas that we need improvement. This is very multidisciplinary and needs to be considered for everyone's role that's played. And need to monitor our outcomes. And again, metrics are important to see how we're doing and how we can improve. Risk assessment, now this is during admission, kind of breaking into two categories, medium risk, high risk. Medium risk can be prior C-sections, multiple laparotomies, multiples greater than 4 births, a history of a prior postpartum hemorrhage, myomas, large neonates, fetuses greater than 4,000, obesity, and low hematocrits, anemia. So for these, again, you would at least want to type and screen. And for the high risk, a previous, obviously suspected accretas, we're not going to really get into accreta. That's a whole nother lecture topic. But those that already have low platelets, any active bleeding when they present, any known coagulopathy, 2 or more of the medium risk would put them in high risk categories. For these, you want to proceed to truly have a type and cross to have blood immediately available and no delays. During labor, the medium risk can be chorioamnionitis, prolonged oxytocin inductions greater than 24 hours, prolonged second stage, magnesium. Again, would want type and screen. And the high risk, active bleeding, 2 or more of the medium risk, which you'd want to actually type and cross.
UFC testing on file.
Other factors, again, universal active management of third stage, which typically is that once the placenta is delivered, to at least initiate oxytocin, pitocin, and massive transfusion protocols, or at least something similar to it, depending on your blood bank. And hemorrhagic carts or kits can be very available. And this can be very helpful, but they need to be readily available. And you can use your own definitions, or people just need to know where the medications are, where they can be obtained quickly and without delay. Once bleeding occurs, using the acronym bleeding, B to be ready, L loss estimation and level, E etiologies of the bleeding, second E estimate blood and fluid replacement, D the drugs, I intraoperative management, N non-obstetrical services, and G getting support during and afterwards. So we need to be a team, and this includes nursing and even rapid response teams if you have those available in your hospital. Again, excellent coordination with blood bank and laboratory, OR crew, depending on what you have available directly in your labor and delivery or immediately available to surgery. Physicians include the obstetrician, anesthesia assistants, and other specialists. Case management, brief and debrief, and be aware of time and input. Not necessarily from postpartum hemorrhage, but for some other comorbidities we've encountered, we're instituting a pre-brief. We identify patients that are at high risk and not our typical, and we try to brief even before there is an issue, and it has helped us in identifying patients and lets everyone in the team know that we need to focus on this particular patient in a different manner than we would our regular patients. Estimating blood loss, again, was the old term. Now we're trying to be much more descriptive with the quantitative blood loss, and we'll talk about some of those methods, which EBLs typically was grossly under using visual estimates. QBL is now the standard for most systems. Estimate the true amount of blood loss, quantify blood loss with graduated cylinders, bags, and weighted pads. Obtain baseline laboratory studies, and I'm going to talk a little bit about obtaining laboratory studies. But one of the things, if you don't take away anything else from this talk, is never ever wait on laboratory studies before you give blood. If you have an impression clinically that your blood loss has exceeded expectations or any changes in vital signs, then do not wait on laboratory studies to return. You need to be administering blood products. And this is more in a classification rather than stages, which we'll really talk about. But class 1, acute blood loss of a liter. This is about 10 to 15%, and these would be the typical clinical changes that you may see: dizziness, palpitations. You may not see a lot of blood pressure change at this point, nor tachycardia. You get up to 1500 when you've lost about 15 to 25% of total blood volume. You'll certainly have changes in vital signs, tachycardia, tachypnea, sweating, weakness, a narrowed pulse pressure. And then 3, when you're up to 2 liters, now you've lost between a quarter to 1/3 of your total blood volume. You'll have significant tachycardia, tachypnea, restlessness, cool extremities, and hypotension. Obviously, the goal would hopefully not ever reach the point of class 3. And then in class 4, greater than 2.5 liters, you've lost 1/3 to close to 1/2 of your blood volume. You're going to see signs and symptoms associated with shock. Dynamics of postpartum hemorrhage. If you look at the systemic vascular resistance, it's going to still go up or try to go up as the blood pressure drops, and then the cardiac output will start to decrease as well. So from a hemodynamic standpoint, you start to see the changes in the physiology. Shock index, the heart rates divided by the systolic blood pressure. A shock index greater than 0.9 is associated with the need for massive transfusion. This is a real quick and easy way to see where you are hemodynamically. Again, take the heart rate and divide it by the systolic blood pressure. And typically, if you're 1 or greater, you are probably already behind in regarding dynamic shock. Again, if heart rate's greater than systolic, the patient already has significant hypovolemia. And don't be fooled in patients with preeclampsia with high systolic blood pressures, because again, as I showed in the other side, their systolic vascular resistance may still be elevated. So you could still have blood pressures that would be interpreted as uh, um, decreased, but not in a severe range in these severe preeclamptics. Identifying the source, now we need to look at where is this blood loss coming from, the etiologies of postpartum hemorrhage. Primary is bleeding postpartum hemorrhage that occurs in the first 24 hours, uterine atony, uh, genital tract lacerations, retained products, or again, accretas with invasion, uterine rupture, uterine inversion, and coagulopathy. And secondary is bleeding that occurs later, greater than 24 hours, up to 12 weeks, can be infection, retained products, placental site subinvolution, coagulopathy. Uh, some of the postpartum hemorrhage risk factors, again, retained placenta, failure to progress in the second stage, accreta, laceration, instrumental deliveries, large babies, hypertension, induction of labor, augmentation. So you can see that it increases the risk of postpartum hemorrhage to 3.5 times with retained products of placenta. And the 4 T's to remember, tone, which is atony or hypotonic uterus, trauma, which can be lacerations, either vaginal, cervical, or even perineal. Retained products would be the tissue, and then thrombin, any form of coagulation dysfunction. And then again, keeping up with the losses. In these situations, you typically want 2 large bore IV sites, fluid resuscitation. Start with crystalloids. And again, you give this almost in a 3-to-1 ratio to what you believe your quantitative, not estimated, blood loss should be. Consider colloids and early plasma replacement. This can be in the form of albumin as well as a hispan or other colloids that can be used and not just strictly crystalloids. So again, you have your type and cross match, packed red blood cells, fresh frozen plasma, cryoprecipitate, and platelets. Oxygenate, keep warm, warm irrigation in the bear hugger. It's very important to keep the patient warm in these situations. It can make a difference in how they recover in the resuscitation. It's not something in the acute setting that we always think about. So again, these form of warmers can be very, very helpful. We typically have them in the OR, but we don't think of access when we're in the delivery rooms. Infusion assistance, rapid infusion systems, pressure infusion bags, infusion pumps, and blood warmers can all be helpful. If we look at each of these products, packed red blood cells have about 300 mils and can increase your hemoglobin by 1 for each unit given. Platelets about 300 mils. This is using if you had pulled 6 units, but you can give single donor, which is in larger facilities is more common than the 6-packs that have historically been used. Fresh frozen plasma has a volume about 250 mils. Cryoprecipitate is not one of the things that we first think of in the acute setting of postpartum hemorrhage, but it's mainly looking at the primary contents, specifically replacement of fibrinogen, von Willebrand's factor, and factors 8 and 13. This is again massive transfusion protocols. I know in the region, most of our facilities will not have the ability to truly have massive transfusion protocols. It's typically 4 units of packed red blood cells, 4 units of fresh frozen with 1 unit of platelets, 4 units of platelets, of packed red blood cells or fresh frozen or pooled cryoprecipitate. And then there's ratios of 10-to-1. Whatever you pick, you need to have one of these. I presented this slide because this is more traditionally, that's what's used in larger facilities. Actually, we've moved it to a whole nother level. We're using whole blood now, not packed red blood cells and fresh frozens. Trauma literature has supported this, and obstetrically, it can definitely make a difference as far as giving larger volumes and already have your coagulation products in the unit of whole blood. Management by stage, and this is probably the one that you need to be most familiar with. Again, stage 0, less than 500 mils for vaginal, 1,000 for C-section. You don't see any vital sign changes. Stage 2 is greater than 500 up to 1,000 after a vaginal delivery. Stage 2 moderate, 1,000 to 1,500. And stage 3 is severe when you start to have significant hypotension and changes clinically as far as their signs and symptoms. Stage 1, again, the initial steps, large bore IVs are extremely important. We have an excellent rapid response team here that if we're having difficulty with access, they can be immediately available, and they can have ultrasound guidance to help us get lines in that has truly made a difference in being able to resuscitate these patients acutely. Urinary catheter is necessary. You want to know how much is coming out. Continue fundal massage. Our medications, which we'll talk a little bit more in detail. Again, your blood bank and the actions we've already touched upon as far as determining where is the bleeding come from. And also already be thinking ahead, what are your next steps going to be if the bleeding is not readily controlled. Indicators for transfusion include evidence of hemodynamic compromise, high rate and magnitude of blood loss, where is the bleeding coming from, response to early measures, medical and surgical, the type and degree of cardiovascular support, and laboratory or point of care data. But again, the real bold type is do not wait for laboratory results to begin transfusion. The stage 2 is the initial steps. This is when, again, you have blood loss up to 1,500, or you've already given 2 rounds of medication. This would be mobilize additional help. I can't emphasize that one enough, because even if you feel like initially you have more help than you may need, you don't want to have to wait when things were turned in a negative direction. Again, the second IV, if you don't already have it, the labs. At this point, even preparing to move to the operating room, and then your blood bank, and then the actions to escalate therapy with goal of hemostasis. And then stage 3, this is when we have greater than 1,500, or we have greater than 2 units of packed red blood cells, or a patient at risk for continued bleeding that we can't necessarily identify. This is when we would definitely move to the operating room. Be sure everyone understands the clinical status of vital signs. What is the quantitative cumulative blood loss at this point? This really needs to be known on a real-time, ongoing basis. Cannot emphasize that enough. Outline and communicate the plan that's going to be from there as far as what to anticipate in the operating room. Medications can still be continued. Your blood bank, again, needs to be able to initiate what form of massive transfusion protocol you can. Oxytocin, you can again look at this 10 to 40 units in 500 to 1,000. We will give even up to 80 units in a liter. And then metrogen, 0.25. Again, this should be contraindicated, or at least relative contraindicated in situations that the patient already has had a degree of hypertension. Hemobate, or 15-methyl PGF, can be repeated actually every 15 minutes up to 8 doses. This is something that I think people forget, that this can be repeated. And even the metrogen can be repeated on an ongoing basis as well. Cytotec can be given rectally, typically up to 1,000 micrograms, and certainly can be another form of creating improved tone to the uterus, and should not be forgotten. Again, just kind of rehashing this drug therapy, the oxytocin up to 80 units, I've said at this point. And then the misoprostol, the Cytotec, up to 1,000. I've never given less than 1,000. If I've reached that point that I need it, then typically you might as well go to the maximum dose. The methogen, again, can be given every 2 to 4 hours on a continuous basis. Contraindications, or at least relative, would be hypertension. And then in hemobate is also, again, has a relative contraindication in asthma. Secondary medical therapy, tranexamic acid, recombinant factors, prothrombin complex, fibrinogen concentrate, hemostatic agents, and calcium. I'm not going to talk about recombinant or prothrombin complex, or particularly fibrinogen concentrate, which would be like cryoprecipitate. I am going to comment a little bit about calcium and TXA. Calcium replacement can be very vital in this point, particularly when the patients are becoming unstable. Can be very important to help in resuscitation. TXA, I've actually reviewed this article very carefully. We did a recent presentation on Accretas, and I think has a great use, but I emphasize it is not the cure-all. If you really dive down into that study, there was an improved mortality rate, but there's actually no change in hysterectomy. And when they say there was a 20 to 30% reduction in postpartum related deaths, there was a change actually, and I don't remember the specific numbers, but it was from about 1.2 to 1.8%. We're actually talking very small numbers. But if you're going to give it, it's 1 gram over 10 to 20 minutes, and it needs to be given within and followed by a repeat dose if persistent bleeding in 30 minutes. If you don't have it on hand in your hospital, I would encourage you to get it, and to be able to give it. But I emphasize to people it should not be viewed sometimes, as it has in the past, as the cure-all for postpartum hemorrhage or for preventing postpartum hemorrhage. We'll dive down a little bit more now into surgical techniques. This will obviously be determined a lot by who your obstetrical providers are and what their comfort level is. But let's not forget bimanual massage. If you think you have retained products, then uterine curettage. Identify the lacerations, arterial ligation, compression sutures, packing, hysterectomy, hemostatic agents, and then again, stage management. 3 groups of surgical techniques. 1, to restore uterine physiology and normal anatomy, to restore the process of normal uterine involution, repair lacerations, remove the retained products, and restoring normal uterine anatomy after an inversion, which is very important to identify early, and the methods and mode to reversing this is important. Decrease uterine blood flow, decrease blood loss, surgical vascular ligation, uterine artery embolization, give time for involution to take effect. 3, replicate vascular compression of uterine involution by tamponade, which is B. Lynch, and uterine balloons, which we'll talk a little bit about. Failing these uterine and fertility salvaging procedures, then your only alternative is hysterectomy. And sometimes there can be delay when you have a patient with this as their first delivery. And unfortunately, you have to proceed with what's definitive. The surgical T's, again, restoring uterine contractility, removing the tissue, repairing trauma. 2, decreasing the blood loss, thrombin, while allowing time for your uterotonic agents to take effect, to restore tone, and providing tone through internal, external tamponade, which can again be external massage, or the balloons, which we'll talk about shortly. Massage. This has to always be maintained It can even be maintained by a hand in the vagina and one external. But even though while other things are being looked at externally, someone should be not only maintaining massage, but determining what the tone is, which then will affect your additional management. Compression sutures, we're going to talk a little bit about, particularly the B Lynch, Heyman vertical sutures, Herrera transverse vertical sutures, and multiple squares. The last two I've never done, but they've been in the literature for a long time. This is the B Lynch. It's very well known. I've done it several times and find significant benefit from it. Typically, you introduce the suture just below the incision, come out above the incision, and then go over the fundus. And on the back side of the uterus, you go horizontal from one side to the other, and then bring the suture back over the fundus through above the and below the incision, and then ligate. We've actually modified this, and if you see where these loops of suture are going over the fundus, we've actually started taking the stitch just through the serosum as we go over the fundus. Because if you don't, as this is compressing down, these loops can come off, and then you run the risk of the loop incorporating bowel, which can lead to GI injuries. So just a little modification I would pass on and encourage people to add this to the procedure. Again, this is looking at the procedure as far as the B Lynch. And again, there's certainly other modifications of it that have been done in the past. This is the other form. Again, you have vertical sutures, horizontal sutures. I've never done these, but people have used this to help compress the uterus as well. And these multiple squares I have never done, but it's actually in Williams. And obviously some people have experience with it. I have seen it used in accretas more so than in apnea and postpartum hemorrhage. These hemostatic agents, these are typically more for continuous venous bleeds. They really don't have any place to be used in arterial bleeds when basically you need ligation rather than just surface control. This is actually something that I would tell providers to look at in the region where they don't have the full means to manage these situations. You literally can take a red rubber, or you can take a Penrose and place it around the lower uterine segment to compress the uterine arteries to give you time to transfer the patient if need be. It's just temporizing. It obviously would not be any benefit long term, but it's creating a tourniquet around the lower uterine segment to maintain control until other modalities can be obtained, which typically would be a potential transfer. And this is the old O'Leary stitch. It's basically in the ascending or descending uterine artery, simply through the myometrium and through the broad ligament, a suture is placed. This is to decrease pulse pressure, and even if you did it on both sides, future fertility can be still maintained. Now we're going to talk about the balloons, and over the last several years, there's been multiple balloons that have been on the market. The two more common one is the Bakri and the Jada, which we'll talk about. The Bakri has become very popular. We've used it numerous times. It has to be carefully placed, though, in the correct position up closer to the fundus. If it's in the lower uterine segment, it will be of little benefit. The negative of the Bakri is because its frequency is not enough that people know to use it without being able to read the directions. There can always be a time delay when the Bakri is placed, but it's relatively inexpensive, and again, should always be in every labor and delivery. Now, which is on the scene is the Jada. which in our facility, we have actually used it as our first preference now. The JADA is easy to place. It's extremely effective. And there is literature that has come out in our journals recently that says this actually should be moved up to an earlier place in the regimen of postpartum hemorrhage. In other words, even using it before you reach the point of having to use multiple agents. Now, the negative and the criticism of that form of treatment is cost, because it is still significantly costly. Hysterectomy again becomes your definitive treatment. I won't go over the procedure, but it has to always be in the back of our minds. And in fact, to the point where if you have hysterectomy trays, at some point in the process, it needs to be brought out and be ready to use, because you don't want any further delays when you've reached that point. Because when you reach that point, you're probably already significantly behind in the blood loss. Non-obstetrical services, intervention radiology, your pharmacy, intensive care. Intervention radiology is something that, again, some facilities may not have, but when you've got a delayed bleed, it is a technique that can be very helpful. Instead of taking the patient back to the operating room, you can identify these arterial bleeds, and by your intervention radiologist to be able to create a thrombosis and create a hemostasis. It is not beneficial in the acute setting of bleeding unless you truly have reached a point that you've already performed the hysterectomy. So again, this is a schematic drawing. It's actually being used in this setting with fibroids, but you can see where the bleed is. And then again, they give the thrombin agents that creates an embolization and forms a clot and stops the bleeding. So what do you do once the bleeding has controlled? Almost always these patients will go to some form of ICU setting. Then you do your debrief. What can we do better? Document the events. Questions do you have? The family's going to need a lot of support. They're going to have a lot of questions. What did we forget? Did we consider anticoagulation? Redosing antibiotics is really big in these situations, particularly in our larger patients. Get help for yourself and your patient. Practice. Postpartum hemorrhage drills are very, very important because, again, it's not an everyday event. Quantifying blood loss cannot be emphasized enough. Prescriptive checklists, simulation devices, walk through with teams on plans, playing oral boards style what's next when reviewing cases or events. Obviously, in a resident setting, this is something that we do frequently at our checkouts. So people involved, again, your primary nurse, your first responders, your second responders, your supervisors, and the MD. All these need to play an absolute role, and it's where communication is vital. There's nothing wrong with sharing your thoughts and contributions at any point in time. Every idea should be considered, and again, working closely as a team is vital. Carts is a big deal. We're actually at our facility looking at some modifications in what we've done in the past. These carts are very, very important. You can have different forms of it. You have to look at what your people are used to, what can be readily brought into rooms. And then we're talking mainly about a labor and delivery setting, but we've looked now more in our postpartum floor. What can we have immediately available? And we're actually moving to have hemorrhagic carts on our postpartum floors as well as just in labor and delivery. And I would encourage that in all facilities, because so often these postpartum hemorrhages don't occur just in labor and delivery. So providers need care too. Some team members, this may be their first near-death experience. Offer support, offer space, offer follow-up, and for serious events, consider coverage for involved team members and providers. These are common mistakes. 10 most treating postpartum hemorrhage as a diagnosis as well as opposed to a sign, and not identifying the underlying cause. Underestimating the blood loss, this is typical. We still see it even here. Unfortunately, sometimes it's anesthesia that's underestimating it. They don't realize where all to look. So again, verbal communication, especially in the OR, is important. Inattention to vital sign trends, delay in laboratory assessment, delay in instituting blood component therapy, delay in surgical intervention, not making a mental shift from a normal delivery to a life-threatening emergency. And then the final three, poor perioperative communication between OB anesthesia regarding who will primarily manage the blood loss, laboratory assessment, blood component. This is very, very big, and sometimes this needs to be determined up front, particularly in your simulations as far as who's going to be assessing this and making further recommendations in your plan. Poor postpartum communication between nursing and the OB regarding what is the QBL, the vital signs, and other clinical indicators. Lack of preoperative preparation for massive transfusion, particularly in placenta previous with prior C-sections or suspected accretas. Preventing maternal deaths, angiographic embolization, again, IR is very important. It's not meant to be a useful tool for massive transfusion initially, as I mentioned earlier. If more than a single dose of medication is needed for atony, go to the bedside until the atony is resolved. Never treat postpartum hemorrhage without simultaneously pursuing an actual diagnosis. And a postpartum hemorrhage with oliguria furosemide is not the answer. Unfortunately, this still happens in situations. If you don't CP, Lasix will not be the answer. Women with placenta previa and prior C-section should be evaluated and delivered at tertiary care centers. If your labor and delivery doesn't have an updated massive transfusion protocol, you need to get some form or certainly have a plan in anticipation. So conclusions, postpartum hemorrhage is a common obstetrical event. It's a major source of maternal morbidity and mortality. Early recognition is critical. Bleeding will guide effective management. Don't forget the 4 T's. And thank y'all very much. If there's any questions, I'll be more than happy to try and answer.
You can unmute or type them into the chat. I put the CNE form into the chat, so if you'll fill that out, you'll get your CNE credit. We will email that to you.